Welcome, everybody, to It's a Wrap with Rap. I am your host, Ron Rappaport. This podcast features extraordinary people who do special things to enrich our lives and also features people who have overcome major challenges and adversities in their lives to come out on top. Today, I am privileged to have as my guest Dr. Susan Partovi from Los Angeles, known as the Skid Row doctor and first responder for injustice, who has been praised for her boundless compassion that she has demonstrated over the last 17 years of caring for thousands of the sickest of the sick in the homeless capital of America. Dr. Partovi graduated from the Sidney Kimmel Medical College at Thomas Jefferson University in Philadelphia. She is a family medicine specialist and has over 26 years of experience in the medical field. She has worked in homeless medicine for 18 years and makes her rounds in her outreach program on Skid Row in downtown Los Angeles, which has the highest concentration of homeless in the United States. She is currently the medical director at Homeless Health Care Los Angeles. Dr. Partovi is known in the community for her tireless work and passion for street-based medicine and advocacy for unhoused people that are gravely disabled. Dr. Partovi is the kind of doctor who wears a jean jacket, not a white coat, carries her medical gear in a backpack, and makes home visits to patients who reside outdoors. She has pioneered the practice of street medicine in Los Angeles, having created successful programs for the homeless in Venice and Skid Row that have become models for today's multi-agency mobile outreach teams that are run collaboratively by the city and LA County. She created the Homeless Street Medicine Program at Venice Family Clinic in 2007 that landed her in LA Weekly's list of most influential people in Los Angeles. Today, she doesn't do outreach like she used to. She directs a clinic once a week that is more of a wound care clinic for heroin addicts. The clinic provides sterilized hypodermic needles to people who inject drugs and prescribes medication and treatment for those who wish to stop. Her patients are the lepers of the American public health system, dually stigmatized for homelessness and addiction, for whom illness is inextricable from shame, and her patients adore her because she treats them without judgment. Just to let everybody know out there in our audience, Los Angeles is fourth in the world in homeless population. 1 out of 250 in LA County are homeless. 1/2 are chronically homeless, meaning no home for more than a year. With all that being said, welcome Dr. Partovi to the podcast.
Thank you. That was a great intro.
Well, thank you. Well, I could have gone on longer with all the accolades because there's a list of them. I will personally say I have done my research on the subject and on you, and the term hero really pertains to you and the people who you work with.
Thank you.
I
definitely represent a group of other, there's other clinicians out there.
There are.
Like me. Yeah.
That's what I said. Yeah, you're all heroes. Take us back before graduating medical school. Were you drawn to doing volunteer work, helping the underprivileged?
I was. I actually was involved with a church group that introduced me to going to Tijuana as a teenager, where we helped build houses. And that was kind of my first experience with poverty. After growing up on the West Side in Los Angeles, which is a pretty posh neighborhood, never venturing towards, downtown LA or, any of the other suburbs that are, not the West Side, basically. And so that was kind of a wake-up call for me even as a teenager, to be really surprised by how other people live. Not just the poverty and the lack of, housing, lack of clean water, lack of shoes, lack of clothing. But then there's also the flip side of like how generous they can be, how happy they can be, how funny they can be. So, I soon started realizing that I was able to relate to them, more than I thought I'd be able to. And then I continued going to the same spot when I was in college at UCLA. I went with this group of people, kind of a hodgepodge of do-gooders from Orange County. Most of them interested in doing like a church service for that population there at the dump site, it was called. And I shadowed a PA named Steve Knopf, who became my first mentor in medicine. And I hung out with him in our little closet-like clinic, and did that every Saturday for 5 years.
Wow.
Yeah.
Quite
So
a
I
quite,
learned,
quite a commitment, at a young age like that, when
yeah,
probably most girls were, going out and going to parties
partying.
like that. Yeah.
Never got into that.
And I bet, doing that type of volunteer work really lifted your spirits and gave you that energy that you could tell that they really were glad that you were there helping them.
Well, it's a mixed bag, right? So there's definitely what you're giving them and what you're getting from them, right?
Uh-huh.
A sense of purpose, a sense of, I'm making a difference for you, but then you're also getting their, like I said, their generosity, their humanity, their humor. And so you build a relationship with them. And
Sure. Sure.
and so I mean, I guess, yes, we're coming to quote unquote help them. Um, but for me at that age, I felt it was more important to go every Saturday because I wanted them to know that I was committed to them. Even though I wasn't a physician, I was just pre-medicine at the time. But that the relationship, and that's kind of always been my philosophy, is that's the most important part than the actual, treating their diabetes, which is important, but
Yeah.
it's second.
So how did you decide to get involved with practicing homeless medicine?
Mhm. So, because of my experience in Mexico, that was basically a done deal as far as the type of medicine I wanted to practice in the future. Now I wasn't sure like whether it would be as a family physician, ER physician, pediatrician, psychiatrist, but I knew I wanted to be working with underserved populations. And so I actually did my residency at a county facility in one of the county facilities in Los Angeles, which is Harbor UCLA. And this was before the expanded Medicaid. So anyone who did not have insurance basically went to went to the public hospitals and the public clinics. And so that was the first step, was going to that residency and then being surrounded by same-minded people. And so I learned a lot from them and had like this kind of like a movement of wanting to improve things, and got involved with the union for the residents union, as well as learning more about universal health care and its importance. And you learn to do everything too, because when you're working at a public facility, when at the time it was, and I'm not exaggerating, a year and a half wait to see a rheumatologist or a cardiologist or any
Yeah,
specialist.
sure.
And so you had to learn how to basically do that kind of stuff yourself. Or you're calling, your colleagues that you've met over the years, saying, who's a cardiologist, going, okay, what do I do here?
Yeah.
So yeah, so we were all kind of thrown in that together. And so the people who, and the mixed bag part is yes, you get a lot of fulfillment, but then there's a lot of heartache too. So it's a double-edged
I can
sword when
imagine.
you're,
Yeah.
yeah.
Homelessness in the United States is actually down 14% in the last 10 years, but it's up 75% in Los Angeles over the last 6 years. As of June 2020, the homeless count was over 66,000 people living in the streets and shelters and in vehicles within LA County, up 12.7% from the year before, 2019.
Right.
What do you attribute that rise to?
Well, at the same time, the county was also working on housing people, especially those who were medically unstable, who were also experiencing homelessness, and so I do want to point out that the county was actually able to house 20,000 people in that time period. And so still had a rise in the count. It's really hard. I mean, if you go back 10 years and look at the count, it's about the same. So there's definitely this kind of mercurial rise and fall. I was once the 2008 decline in our economy hit, I was waiting for homelessness to be climbing ever since then. So there's always going to be the economic issues. I think there's a couple, and another chronic issue is people who are dealing with severe mental illness and are not getting the treatment that they need. And that's a huge issue. 1/3 of the homeless population are severely mentally ill. And so that's not really being, I mean, it is being addressed to, I don't want to blame Department of Mental Health that they're not doing all that they can, but I will blame the state of California for not doing all that they can. And the other issue is drug use, and we've developed this scourge of meth use. And I just spoke with Sam Quinones, who wrote a book called Dreamland, which was about the opiate, like how the opiate crisis, came about. And now he's writing a book on meth. And he was saying that the meth that's being used these days, for some reason, they have these properties that cause symptoms similar to schizophrenia, so psychosis.
Right.
And so I didn't know about that. I just knew that there was a lot of people using meth. Almost everyone I come into contact with, I'm not saying it's 100%, but it's a large percent of people are using meth, and it's really messing with their mental stability. Now, the question is, what came first? Were they homeless and now they're using meth, or were they using meth and now they're homeless? So it's really hard to say. One thing I think that people are focusing on when looking at the numbers is actually, it looks really bad right now. Like
Yeah, it doesn't look good.
Better word, right?
Yeah.
Like Skid Row looks really bad, downtown looks really bad. Even Venice, where I live, there's encampments around here. It's so visible. And that's one of the differences, is that 10 years ago, they weren't allowed to create encampments. They weren't allowed to stay in a tent during the day. They had to break everything down and go along their way. And so they were nomadic. We did not see them, and they did not form like these little mini communities, because they were changing their spot every day or every night. And so now people are kind of permanently in a spot, because it's easier to keep your things that way and have other people kind of help you out watching your stuff.
Sure.
And people are drawn to community, and so I think that it has looked really bad because of the visual of, like, we see everyone's tents, whereas before people were hiding in the alley and sleeping overnight.
It was more invisible back then.
Yeah,
so to
it's
speak.
now more visible.
So
So
do you,
that's
I'm sorry, but do you think, not the legalization, but didn't they take the meth uh, possession and make it a misdemeanor instead of a felony? Didn't they downgrade it?
I believe so. I don't know if that's meth or all drug use. And if that has happened, that's a recent thing. To be honest, I think uh, the criminalization of drug use is really horrific and is really um, probably has caused a lot of homelessness, if anything. I mean, if you go to prison, man, it's really hard to come back from that. It's like hard to get a job. It's hard
Sure,
to rent a place. Like you have to
sure.
say, yes, have you been in prison before? Yes, there's nowhere you can apply for without being asked, are you, have you been to prison? And so, and when you look at the California prison system, prior to COVID, it was probably 70% related to drug use or drug possession. Now, I'm not saying drug or drug selling. Selling of drugs, I think, is different than possession and use.
Oh yeah,
Um,
absolutely.
but for people who are using drugs, I mean, just putting them in prison, they're just going to use again when they come out. I mean, some actually do rehabilitate. I
Yeah.
actually know people who got clean because they went to jail. But that's for, I would say, maybe 5% of the population. The other 95% are back on the streets using again. So that's not the way to address
I
drug.
agree with you, and the reason I brought that up is because I was just wondering if it was, and I think it was brought down to a misdemeanor where,
Mhm.
probably nothing really happens other than a slap on the wrist. It could be driving people from other states to California, where it's
Hmm.
a harsher penalty. I don't know.
Well,
I'm
I
just
mean, there's a lot
asking.
of reasons to come to Los Angeles if you're you know not housed and kind of trying to look for a better life. A lot of people come here just for the weather alone.
Yeah.
Some people come looking for business in the industry, and for whatever reason don't make it. So I haven't heard that being uh, something that lures people to California, but it's a possibility. I'm just not aware.
I don't know. When I read it, I went, oh, well, maybe they're coming from other
Yeah.
places.
So,
Uh,
so one of the things, if you look at, say, I mean, Portugal, they completely decriminalized all drug use. And if you look at their statistics, um, they're like some of the social factors have really improved, including homelessness, including drug use. Like drug use went down because they decriminalized it. And the Netherlands are kind of following in suit with a more leniency towards drug use. So I think there's something to be said
yeah, I agree.
about that. And uh, I think when people are addicted to a certain drug or multiple drugs, they're they're experiencing homelessness. They're in survival mode
Ab-
nonstop. And
Absolutely.
so they don't have the wherewithal or the bandwidth, whatever you want to call it, to go, maybe I'll, get clean now. It's like, no, they're like, it's
Right.
like they're in survival mode. So if you take out the survival mode and like having to hide, from the cops and using in the alley and not, where you're at risk for overdosing and dying. And, um, I think, I think, I think homelessness would start to improve.
Dr. Partovi, could you tell our audience what is the makeup of the Skid Row population? And I read where some mental health facilities were just simply dropping off discharged patients there like it was a dumping ground. I don't know if that's true or not, but that's what I saw on a video.
I mean, that there was I mean, I think that was about like 13 years ago. You know, there was a big there was a big issue made out of dumping people from the
Uh-huh.
hospital. I don't know if there's been anything specific to mental health hospitals per se. Um, and the way they get around that is, so if you're mentally ill and you were hospitalized involuntarily because you were a danger to self or others or considered gravely disabled, um, and they gave you some medications for like 3 days is the max where you can be held involuntarily on a 5150. And then if after 3 days of, you know, taking these medications and not using meth or other drugs that could be exacerbating your mental health issues, what they do is basically say, you know, where are you going to go? And they'll say, oh, I'll go to the shelter on the corner of blah, 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 blah. Well, where are you going to, you know, get food? Oh, well, this mission, they give out food, you know, twice a day. So I'm going to go there. Where are you going to get your clothes? Well, that mission, you know, so they basically verbally ensure that they're going to be able to take care of themselves, not really taking into account their history, and their the experience that other people have had with them. It's just more in that moment. And then they'll give them bus tokens to go to the shelter. So that's kind of, I mean, it's a very, you know, I don't want to blame the psychiatrists or the social workers by any means, because it's a very difficult system in that there's really nowhere to put people who are suffering from severe mental illness and who can't get better in 3 days. And so they can stay for 2 weeks. But then if they need to be what's called conserved, like saying like there's evidence that this person really cannot take care of themselves, like they are a danger to themselves if they are released on their own cognizance, there's no facility to send them to, because they're all full. And so what happens is the hospitals, so say, well, I'm not going to mention a hospital because I don't want to get anyone in trouble, but
No.
say they're at a hospital that is or is allowed to have holds. So they're allowed to keep people against their will, because not all hospitals are. And a psychiatrist has designated this person that they need to be conserved. It can take up to 9 months before they find a place to actually place them. So what happens is Medi-Cal nor Medicare, and you know, most people who are mentally ill on the streets don't have private insurance, but
Right.
even private insurance doesn't pay beyond the acute 3 days. And then you might be able to say like they're still acute for a couple more days, but beyond the acuteness of their disease, Medi-Cal will not pay. And so that means that the hospital is boarding someone for 9 months, which normally they get, let's say, $500 a day. They're getting $0, you know. So they
No
have
money.
they're very they have a disincentive here to not hospitalize people and say that they need to be conserved, because then they take that risk of not getting paid for a boarder.
It always comes down to money, doesn't it?
Yeah, it does. And if you think about in the early 90s, pregnant women who were undocumented did not have medical insurance for when they were pregnant and to cover their prenatal care or to cover their delivery or to cover their postnatal care. And so you had tons of people delivering in the county facilities, right? But you also had tons of kids in the neonatal intensive care unit because these women weren't getting prenatal care. And so like their kids were dying, or they were, or being born sooner than they were supposed to, needing to be in the NICU. And as soon as California negotiated with the feds that Medicaid would now cover all pregnant women. So this was like probably 91 or 92. So, and despite your documentation status, everyone was granted medical care while they were pregnant. So all of a sudden you have Cedars-Sinai, like the nicest, shishi hospital in LA, building birthing rooms because they are trying to compete for those patients now, because they will get paid well to take
Yeah.
care of them as prenatal. So that's the kind of thing that we need. We need California to really figure out how Medi-Cal can participate, and then the state as well needs to participate in funding these long-term facilities so that they're nice facilities, they're appropriate for where they're at in their ability to take care of themselves, and that they're places where they can thrive and take their medications appropriately.
Right.
So that's the dream.
That's a dream.
That's the
Skid Row in Los Angeles has been described as hell on earth. Could you describe to our audience what it's just like physically, and what kinds of problems the homeless face each day just trying to survive?
Mhm. Um, it's pretty disgusting, from on so many levels, like just a humanity level.
Yeah.
It's disgusting, but it's physically disgusting. There are, areas of trash. It's literally 10, 10, 10, 10, 10, 10,
Yeah.
and thank goodness they've put in, because of COVID, they've put in bathrooms and places where people can get water, like water fountains, and places where people can wash their hands. Before COVID, that didn't even exist. So
Wow.
people just go to the bathroom in the curb, on the
Yeah.
streets. Um, there is a, a lot of drug use going on, more so than the rest of the county, I would say. And there's really severe mental illness. I mean, there's like, you can just walk there and within a minute, someone will just be like walking, like half naked with like this, horribly soiled, whatever thing
Yeah.
wrapped around them,
Yeah.
and just kind of out of it, and walking in the middle of the street. Like it's like uh it's like the 1600s in England or something.
Gotcha. The
Yeah.
medieval times. Yeah.
Yeah. So I mean, if there's certain people, like as you get to know certain people, again, you develop a relationship with them and realize that there's a lot of commonalities and you can relate to them, um and again, like appreciate their generosity, their humor, their humanity. um but if you're just kind of walking around, and it's really, really sad.
How many blocks does it entail?
So Skid Row, I believe, see, it goes from Central Avenue to probably Maple. So that's like like 5 blocks. And then from 3rd Street, no, yeah, then 3rd Street to 7th Street. So that's another 4 blocks. So 20
Okay.
block.
So it's a pretty decent sized area.
Yeah. Yeah.
Dr. Partovi, what are some of the common medical conditions the homeless experience that you treat?
Yeah. So in general, actually, they have a lot of the same things that everybody else in the population has. So they have high blood pressure, they have diabetes, they have heart disease. However, you know, they if they're not having access to medical care, they've got the nth degree of what happens when hypertension or diabetes or heart disease isn't controlled.
Right.
So they develop heart failure really quickly, or they lose a limb because their diabetes is out of control. So you'll see a lot of the end result of those common things not being taken care of. But unique to, I mean, there's definitely a lot of dental issues
Yeah, I
because
can
that's going
imagine.
to be lower on your priority list.
Yeah.
And it's really hard to find it. You can't just walk into a dentist like you can walk into an ER and say, hey, I need my diabetes medicines. But you can't really walk into an ER and say, hey, can you pull my tooth?
Yeah.
Like we can give you antibiotics and pain medicine, but we can't really do anything about the tooth. And then there's a lot of skin issues. So for people who have difficulty keeping up with their hygiene, there's different types of infestations that they deal with, or certain infections that they can deal with, or like fungal infections, bacterial infections, infestations like scabies or lice. Um, and it just depends. Usually that's someone who's pretty severely mentally ill that's not able to keep up with their hygiene because it's not doesn't bother them,
Yeah.
or someone who's a pretty severe drug user to where they can't be bothered with their hygiene. We also see a lot of feet issues, if you can imagine.
Yeah.
So, it's something I like to do is, that they have corns, pare down the corn, clip their nails. I remember one of my mentors, Jim O'Connell, Dr. Jim O'Connell. He's like the grandfather of street medicine out of Boston. He's not that old though. He's like one of the first people who actually started it. And he started, I think when he was like an intern, he was in charge of like the feet soaking clinic. And at first he was like kind of like, why do I have to do this? And then he realized how important it was,
Sure.
especially when it's so cold. They actually deal with trench foot and frostbite and stuff.
We know Skid Row is a dangerous place. What precautions do you and your staff take when you're out there doing your
Mhm.
outreach?
Well, I don't go at nighttime. We usually say don't go out by yourself. Um, I usually don't feel afraid. That could be because I'm used to it and people kind of know me.
Yeah.
But if someone's sounding violent, you go the other way.
Yeah.
You don't engage. If there's a fight breaking out, you don't engage. You
Right.
know?
Don't need
So
to be part of that.
no, no, and it's actually not very common. I mean, unfortunately, we did. There was a street outreach worker that was killed a few months ago, a couple months ago.
Mm.
Um, Allegedly by one of her clients. And that was like, I believe in Echo Park. But I mean, that's the first time I've heard of that in LA. So obviously it happens, but when you're talking about violence, and I'm going to stick to the people who are severely mentally ill, their level of violence is on a much lesser level than the general population. And so if a violent act happens, it's more likely going to be from someone who's not mentally ill. Now the drug use, it's hard. Again, meth is pretty much the only one, well, PCP probably, and spice. Those are the ones that really alter your personality and make you do things that you might normally do. Maybe alcohol too. Um, I guess I just like listed the gambit of meds, but heroin, no, it makes you, it doesn't make you violent at all. It makes you very mellow. And benzos and opiates in general, but
Gotcha.
I'm not saying one's better than the other, but there's
Yeah, they all have their
we didn't when I first started
pluses and
working
minuses.
when I was first started working at homeless healthcare, nobody was using meth. Like none of the, at the Center for Harm Reduction where I work, once a week, where we do a lot of wound care because of injection drug users, but it was all heroin users. And it wasn't until like the last 7, 8 years that we started seeing meth injection users. And now it's almost everyone who injects heroin also uses meth.
Wow.
Yeah.
What are
And that's
some
just anecdotal.
what are
Yeah.
some of the biggest myths out there about the homeless? Can you think of
That
any?
they're violent, that they don't care, that they want to be homeless, that they're all drug users, um, that they're loners and don't want to, interact with society. That's all. Like if you can treat someone, you know, normal, for lack of a
Yeah,
better word, like a
yeah.
normal person,
Human. Yeah,
yeah, they show up like a human. If you treat them like a dog, they're going to show up like a dog. But if you treat
sure.
them like a human with respect, that's how they show up.
Let me ask you, what has been your experience in observing how the homeless are treated in the hospitals and the emergency rooms, and what are some of the biggest mistakes people make about the homeless?
So it's a mixed bag. I also do urgent care shifts for the county. So I don't see it as much as say the ERs do, but it's really difficult for them. I would say, a lot of them come for either minor issues like med refills or major issues like they're having a heart attack. Those aren't the ones that are difficult. The ones that are difficult are usually the severely mentally ill or the severe drug users that have altered their personality to where they're not really aware of their surroundings. And so, we had someone, we just had someone over the week, over Monday, I worked Monday at urgent care, and we had a woman who came in saying that she was suicidal and her leg hurt. And then when we were trying to deal with like how are we going to deal with her suicidality, she's like, oh no, I'm not suicide, but my leg hurts, I want that addressed. So then they had her lying on a gurney. And so by the time I got to see her, I'm like, hey, Miss Whatever, it's Dr. Partovi, she's like, leave me alone, I'm like, well, you said that your leg hurt. What's going on? Tell me about your leg. Leave me alone. And she basically, it's cold outside and she wanted to,
Yeah,
we just let her sleep until we closed, basically.
let her warm up.
So there was nothing really, so I think that's
Yeah,
a common scenario where a lot of ERs have to deal with severely mentally ill and, and trying to figure out, like, is there something really acute going on? Or is this someone who just trying to come in from the cold? So I think it's really difficult on the staff, because you feel bad. Like the whole time we're like, all right, well, she's not talking to me. So, like maybe a half an hour before we close, we got to call security so that they can, and sure enough, she wouldn't leave. So they had to call security. I mean, I feel really bad because, it's been really
yeah,
cold for us anyway,
right.
but yeah, I just wish we had a place so we can go, okay, why don't you stay here?
Yeah.
So, and then, I think the other thing that's really difficult to tease out, when someone comes to the emergency room, like very psychotic. So is this their baseline? Like, do they have an organic psychiatric disorder? Is this from an acute meth use gone wrong, or is this from chronic meth use? Now we're seeing that people using meth are actually developing chronic symptoms of psychosis, not just when they use. Or is this something like sepsis, where it's causing what we call delirium, where it alters their personality and can look a lot like psychosis, and especially if they're homeless and look a little disheveled, that might be hard to tease out. So those are some of the things. As far as things that I would blame, that I would criticize the hospitals for, is there's still a, there's still a lot of what's it called, derogative feelings towards drug users, especially when it's obvious that they're a pretty severe drug user. Like, that's one of the reasons why we started having medical available at the Center for Harm Reduction, previously known as the Needle Exchange, is because they were treated so badly in the emergency rooms that they wouldn't go to the emergency rooms and would rather have like their arm fall off and deal with that.
Yeah.
And then there was also at the time really long waits for non-emergent, issues. So it's hard for drug users to wait that long. So so there's still a lot of stigma attached, and one of the things that I think the county, mostly from the work of like 1 or 2 or 3 people, is they started really taking opiate use seriously. Because my experience is, like, I would have a patient come to me, with symptoms of heart failure, and say, okay, let's take you to the hospital. And she's like, I already been to that hospital, but I had to leave because they won't treat my need for opiates, and this woman, she had been to 3 different hospitals. 2 weeks later, she was dead.
Wow.
And so I've seen, I had a patient who was hospitalized. He is very anemic, bleeding from somewhere, and they wouldn't give him opiate replacement medication because he wasn't in a methadone program. It's like, well, like, the goal of hospitalizing someone is to keep them there, treat them, and just, and because they can't handle the withdrawals of their opiate addiction, it needs to be handled so that they don't die. So I think that's one of the things that we're slowly, and it's probably different in different counties, and again, the county system is starting to kind of have a different culture around that. But
that's good. That's good.
I doubt the private hospitals are.
No, probably not.
So and things take time for cultural shifts and comfort, but unfortunately people die as we're waiting for
that is the
to be
unfortunate
comfortable
thing.
to prescribe methadone when they're in the hospital. So that would be my biggest criticism, if there is any. And I'm not saying all doctors are like that, of course.
Right. You know what happens. How do you gain trust with the homeless?
I'm pretty laid back. I think we use anything as an engagement tool. Like, like you might see someone who needs a pair of new socks, or we're like, hey, you want some new socks? It's whatever it takes. Oh, you have a little scrape there, do you want a Band-Aid? This one time, this is a good story. When I was working in Skid Row, doing street medicine there's one guy that we were really worried about, but he would never come to the clinic. The clinic was only 2 blocks away. But he had asthma and he couldn't walk, and so he was always kind of lying inside the tent. And so so then his buddy, who doesn't really have any medical issues, was like, hey, what should I do about my nails? And he had really long nails, and I'm like, I can cut them for you. So I'm here I am on the street cutting this guy's nails, and basically giving him a pedicure. And from that, the buddy decided to start wheeling him to the clinic. So I was able to get buy-in from the buddy.
Gain
That
the
way. And
trust.
listen, for other people, it could just be like, seeing them and talking to them, just, like one guy I saw, he had EKG stickers still on his chest,
Yeah,
from
yeah.
obviously, and he had a hospital band, and it was a hot day, so I think he didn't have a shirt on, and this was like really like on St. Julian, the crux of Skid Row, and I'm like, hey, looks like you just got out of the hospital. He's like, yeah. I'm like, well, what was going on? He's like, oh, I have heart failure, but I can't remember to take my medicines. And I'm like, well, come to the clinic, literally half a block away.
Right,
And
right.
he's like, well, maybe. And so just once a week I'd come out and say, hey, how's it going? And so finally, I think this one time he's like, well, what are you going to give me if I come to the clinic? I go, what do you want? And he's like, I want a hamburger with chili fries and bacon, like the worst thing someone with heart failure because of the salt content. I'm like, fine, I will buy you a
Whatever it
hamburger with chili
takes.
fries. And I go, if you come to the clinic, I will
Yeah.
get that for you, but you have to be stable on your medicines because it'll send you to the hospital. And the next day he came to the clinic.
Did he?
Yeah.
That's great.
And
That's
I
good.
was able to start him on his medications, and he was using cocaine and alcohol regularly. And he slowly got down. We got him into interim housing, and then like within 6 months we got him into permanent housing, and he was coming regularly to his clinic visits, and he was like not using cocaine anymore, and maybe having a drink here and there. And at one point I'm like, well, do you want your hamburger? And he's like, nah.
No?
Because he knew it's not necessarily good for you, but he was so happy with his, when he got the keys to his house, he came and showed them to me.
Yeah.
And so
It's something.
you just got to figure out like how, it's usually just a very lackadaisical, how's it going? Is there anything I can do for you? And it's just the persistence.
Yeah.
And I also use humor, and I just try to be down to earth with them. And if they see me and tell me to fuck off, I'm like, okay, have a nice day.
Yeah.
And then come back the next day or the next week and go, hey, need anything? So
Dr. Partovi,
everyone's different.
yeah. What people do you look for, like, to treat first when you're out there on the street, like a triaging type of thing?
Yeah, so we're going to look for the more vulnerable, fragile people. So that would be elderly, severely mentally ill, people who look like they have the EKG stickers,
Yeah.
look like they have a severe or like you see someone in a wheelchair with like a urine catheter in the urine bag. I'm like, okay, we need to address that, or
Yeah.
they've got like the portacath coming out of their chest. It's like, all right, I need to figure out what's going on there. So those are the ones that I try to engage. So those are the ones that are a little more difficult. There might be more on the fringes. They might be less likely to be in encampments. The good thing about encampments, though, is people kind of look out for each other. So they might go, "Hey, Joe Schmo's doing really bad today. Can you go check him out?"
Uh-huh.
So that's, but usually if someone's in an encampment, they're a little bit more, they're a little bit better off, whereas they isolate themselves. Those are usually the severely mentally ill.
Let me ask you something. What situations break your heart the most practicing this type of medicine?
The severely mentally ill.
The severely mentally ill.
Yeah. Because they don't realize, uh, someone might say, well, they want to be homeless. Look, they say they don't want this, they don't want that. And you kind of have to equate it to like child. Like if your 5-year-old has cancer and they're kicking and screaming saying, no, I don't want it. Like, first of all, you don't not do the cancer, but you do you talk to them and you try to understand what their fears are and you have a relationship with them. And in the end, you say, I'm sorry, honey, but we got to do this,
Yeah.
and it's kind of the same thing. I mean, not to say that, people who are severely mentally ill are at the level of a child, but when it comes to their rational, their ability for rational thinking, it's often not there. So I saw this one woman. So this is an example. Like, my nurses were telling me about this one woman that they were worried about, and she actually had like a wound on her breast. And I mean, anytime you have like a huge massive wound on your breast, it's cancer until proven otherwise. But she was refusing to see a doctor, get surgery, chemo, the whole 9 yards, nothing. So and she lives in her van with all these birds. So I'm like, so I'm immediately thinking, okay, well, it sounds like she's mentally ill, right? So we go to the parking lot where her van is, and I start talking to her, and she lets me see. Oh, it was just horrific, just a horrific tumor. And I'm like, well, what's keeping you from going to, get treatment? She goes, well, I really don't believe in allopathic medicine. Like, I want to be more holistic. And I'm like, okay, like that. And then everything else she said from that made sense to me. Like, I don't agree with her, but it made sense, right?
Yeah.
So she's not someone that I would consider doesn't have the capacity to make medical decisions for herself. She does. Now you go to, someone else. I once had this one woman, a little bit old, actually not elderly at all, but she just seemed a little older. And she said that she had a hemorrhoid and she wanted me to look at her hemorrhoid. So we finally got her, this is in Hollywood when I was working at Saban, we finally got her to the clinic so I could see her hemorrhoid. And it was this huge, like, excavating ulcer of the anus, like clearly cancer,
Yeah.
and hey, thank goodness I actually, made the
So,
effort
yeah.
to, her hemoglobin was like half normal. But she was someone, like, she was very, she definitely had schizophrenia, in that, the CIA was out to get her, and the walls were all tapped, and she didn't want to go to the hospital because there's wires all over there, and she's been warned to not go into hospitals. Like, that's not a rational reason to not get medical care. Then we finally convinced her to go to the hospital, and we're trying to convince her to do a colonoscopy, and she was refusing to do the colonoscopy. And when we said, why are you refusing? She said, because I'm afraid that they're going to find cancer. And that's a rational reason,
Yeah.
so you kind of have to, I'm not saying that everyone who's severely mentally ill doesn't have the capacity to make medical decisions for themselves, but the ones that are like dying on the streets, barely moving, only surviving because they're in the middle of Hollywood and Vine, and people throw them food every once in a while. But meanwhile, they're like surrounded in their feces and urine because they can't barely move. And they're like, okay, well, I'm okay, don't worry about me, because they don't have the ability to make rational decisions for themselves. We actually
Yeah.
had we actually had a guy recently in Hollywood. My friend was calling me to ask me how to deal with this situation where this was a newer person that they had seen, and the people in the neighborhood were kind of saying he'd been there a month, but at first he was able to walk, and now he wasn't able to get up and walk. And so when she first saw him, he looked pretty bad off, but he was able to say, no, I'm okay, everything's okay. And he let her take his vitals, they were okay. She comes back the next day, he hadn't moved an iota.
Wow.
Like, so clearly something's wrong. So when they called, so this is how bad it is. When they called the paramedics say, if he refuses, we cannot take him because that's kidnapping.
Yeah, right.
So, but then you have to ask yourself, is he making the best decisions for himself? So then so thankfully that same day, a social worker came and was able to put a hold on him, saying that he was a danger to self. He was taken to LAC USC, and it was actually discovered that he had had a heart attack. He was in full cardiac failure, renal failure, severely dehydrated. So he would not have lived another day.
No.
So the other thing, though, is he's not mentally ill. He was delirious. And so he was saying no, because whatever he has dementia, and he was delirious from being so sick. And so that's the kind of thing where we really need to be taking severe mental illness seriously.
Yeah, absolutely.
And really seeing that they're at risk for death, but not just that, like they're suffering, and they're going to tell you, no, I don't want help, but they can't tell you why. Or they might give you a reason, or they might tell you why. Like I once had a woman say, Jesus put me in Skid Row to take care of everyone. So I have to stay here. I can't go to the hospital. I can't go to recuperative care, because, that's not an okay answer.
Right.
That's someone who cannot make medical decisions for themselves. So we really need to be able to tease that out. And that's the most heartbreaking for me, really. And what's worse than seeing a severely mentally ill person on the streets who can't take care of themselves is seeing a severely mentally ill person in jail. Even worse, because
Yeah.
they're at the full effects of their psychosis. It is in full bloom, and they're naked, they're eating their own poop, they're swimming in their own poop and pee. I mean, it's the worst thing I've ever seen.
That
So we
is
need to stop putting severely mentally people in jail for
absolutely.
stupid shit. And, if they kill someone, that's another story. But, if it's because they stole a bag of chips, get over it,
Yeah.
and put
Right.
them into treatment or whatever.
Dr.
So, yeah.
I was going to say, I know you train medical students in street medicine. Have you been getting students that are wanting to pursue this line of medicine, or are they few and far between?
I mean, so the medical students, I haven't had medical students lately, but I've had, before COVID, I'd have like some USC medical students rotate with me, but I think it is the ones that want to, be seeing this population. But I always have like a bunch of pre-med kids, volunteering as my little helpers. And they're actually they're kind of like I was when I was going to Mexico in my early 20s. They're very dedicated. They want to learn as much as they can, and they're really compassionate. And so I think it's really important to really foster that philosophy in them before they get to medical school or residency, right? So
Right.
yeah, once they're in residency, it's a done deal. But I usually work with residents from Harbor, UCLA, or Drew, King Drew, in the Department of Family Medicine. And both of those residency programs specifically recruit people who want to be working with that population.
Well,
So
that's good to hear.
yeah,
Definitely.
it's fun for me too. Yeah, I really
Yeah.
enjoy kind of fostering that way of life and that philosophy.
Well, working on Skid Row, I'm sure can be draining at times. What keeps your spirits up and gives you the push to keep on going and make a difference helping?
Yeah. Well, when we started going out in Skid Row in 2014, we started doing it once a week, and we had a really good um, group of people where it was a nurse from one of the Recoup Care sites. It was LAPD. It was a psychologist, and I think what was really helpful is that we would debrief afterwards, and so, you know, it would really allow for us to kind of vent a little bit. Um, and then once they created it into a more formal program with a lot more people, and it was a daily event, I was going out like maybe 3 times a week. I think they still had a good sense of getting together and talking about things and venting and debriefing. But to be honest, like I was really burnt out just from being out 3 days a week. It's really hard.
Yeah, I can
And
imagine.
so your highs are high and your lows are low. That's what I always say. So your highs are so and so just got an apartment, and
Yeah.
they're so happy and you're like on cloud nine. And your lows are so and so died, or so and so's in jail, or you know, yeah.
You talked about the harm reduction program. Can you
Mhm.
tell our audience uh, what that is pertaining to substance abuse?
Yeah, I mean, you can pertain it to anything, but what it means is you meet them where they're at. So if and you participate in improving their health or their lifestyle in any way possible. So if I'm working with someone who uses heroin regularly, and isn't at a point where they want to stop using heroin, I'm at least uh, I'm teaching them how to use the needle in the most sterile way so they don't get infections. I'm talking to them about using a new needle each time so you don't get infections. I'm talking to them about not sharing needles so that, so the idea of having the needles and the alcohol pads to clean your skin and all this stuff, that it doesn't, like, they're going to use heroin no matter what, right?
Right,
So do you want them to be using toilet water and the same needle from Joe Schmo? Or do you
right.
want them to be using it in the healthiest way? So again, it's kind of like taking that survival mode. And so what it is really meeting them where they're at so that they don't feel judged and they want to come back. And so that's really like creating a healthy environment where people want to come back is really key. And that's the goal of being a physician too. Like, my goal is that they want to come back, not that they're going to stop using heroin, but that
Right.
they're going to want to come back and see me. And over time, they trust me, and they only want to come see me, and very few times I say, you know what, you need to go to the emergency room. But for the most part, I can take care of them. And then when they're ready, they're like, okay, I think I'm ready. And it's like, okay, well, we have a program.
Right.
Let's talk to so and so about you joining the program and getting off heroin.
Harm
And
reduction, good philosophy. Definitely.
yeah, I mean, you can even use it for like diabetes,
Sure.
like if I tell someone like, hey, you have diabetes, you can never eat cookie, candy, cakes, soda,
Right.
for the rest of your life, they'll be like, screw you,
Yeah, that's not going to work.
Right. But you can say, all right, this is what makes your sugars high. And having high sugars is bad because it causes this. So what are some things that you think you can do that could help keep your sugars? So that way you get buy-in, basically, because it's their decision,
Right.
telling them that, they have to do this or they can't do that. And so like this one time I got an answer where like, well, I drink about 2 liters of Pepsi a day. Maybe I can cut it down to 1. So I was like, okay.
Yeah, we're making
A, I did
progress.
not know you were drinking that much soda. And 2, that's a good goal to have, So yeah, so the idea is just, giving them a safe place to say whatever they want and not feel judged. And because you're not going to come back if you feel like someone's condescending towards you, I'm not going to go back.
Right.
I went saw a nutritionist once and she told me that, my diet Pepsi was bad. I'm like, fuck you. They told me my diet Pepsi is bad. I never went back.
Can you tell us about some of the services Homeless Healthcare Los Angeles offers the homeless?
Yeah, it's actually quite an array of services. The first thing that I think that they started doing is that they have an outpatient drug treatment program that for mentally ill people experiencing homelessness. So that was kind of the beginning of homeless healthcare's target population and service. And then they've created so many different programs. So they also have a program where they triage people who say they're court ordered to go to some kind of drug treatment program, or like DCSF is requiring them to go to drug treatment. So they can do an intake, get a sense of what their needs are. And there's so many different treatment programs out there. They can recommend which one is the best for you. So it's like a triage and so it's not just us, but it could be any other drug treatment program in LA County. The other thing we do is we contract with the Department of Health Services, and where Department of Health Services pays for permanent housing for people, especially it started with people who are very medically vulnerable. I think they're widening the net a little bit these days, but so this part of the agency does the case management for those people. So we contract with Department of Health Services. We also manage, there is a what's it called? Like a residence for people who are diverted from jail, who are mentally ill, and we run that program. So there's like 50 people living in this facility. Homeless Healthcare runs that program. We're also building, I don't know if you saw in the LA Times, I think it was a couple of weeks ago, where Homeless Healthcare has paired up with an investment group, and they've figured out how to build a residential facility and not have it cost $600,000 per room, like it's like a tenth the price or something like that.
Yeah.
And they're also being able to do it really quickly because they've figured out how to kind of circumvent the bureaucratic aspects of buildings,
Yeah.
things like that.
I heard somebody, some woman out in Venice, Ursula, I can't think of her last name. No, Soledad. Does that ring a bell? Soledad Ursula. Well, they were talking about housing, and they were building units in Venice, 450 square foot apartments, 1.2 million.
Yeah.
Crazy.
Per apartment or
per unit?
the whole?
Yeah, because the contractor was getting
Right.
money, and the architect and
Right.
all that stuff.
Yeah, so there's a lot of, and then of course we have the Center for Harm Reduction where we have the facility in Skid Row, and where we are specific. Oh, and we also run the the refresh spot. So I don't know if you've heard of the refresh spot is also in Skid Row. It's a place that people can come take showers and get new clothes and do their or do their laundry, charge their phones,
That's great.
hang out. Yeah, so that's a really so that's just up the street from the Center for Harm Reduction. So yeah, we have a lot of things going on. I think we do something with the jails too, but
Hard
it's
to
hard
keep
to
up
keep
with all
up.
these programs.
Yeah,
Yeah.
and we
There's,
do a lot of advocacy and looking at grants and stuff like that. So we definitely do advocacy around mental illness, homelessness, drug use. Yeah, that's
does
our gig.
HHCLA, do you guys plan to expand to other areas outside of Skid Row? Because I know there's homelessness a lot
Yeah,
of
well,
places.
so one of the things I didn't even mention, we have a street medicine team. So we have a nurse practitioner, and I'm the medical supervisor for that, and I go out every couple weeks with them. And that's not in Skid Row, so that's in like Echo Park, Westlake, Koreatown. So that's our jurisdiction for our outreach team, which is contracted through the county. But that's another hat we wear. So yeah, and in fact our main site is not in Skid Row. It's in Westlake. So
Okay.
yeah. So
And ending up, what are the ultimate goals of street medicine, and what are you most excited about going forward in regards to uh, HHCLA and what they do?
so there was multiple questions in that. so so
Ultimate goals of
So
street
one of the
medicine.
things, okay, so the goals of street medicine, in my opinion, is to find the most fragile, vulnerable people who are experiencing homelessness, usually because they have some kind of medical, mental health, or drug use issue that's either making them sicker or keeping them homeless, or they're at risk of death. So that's the goal, in my opinion, of street medicine. And we're trying to lure them into services. So like the guy that I promised a cheeseburger, bacon cheeseburger with chili fries, we're doing anything to lure them into services. Ultimately, we think that permanent housing is obviously the answer. But I think interim housing is really important too, which means, like, if I see someone and I'm like, okay, they're not sick enough to be hospitalized, but they're not doing so good and it's raining, I want a place to put them, like
Yeah.
today, so emergency housing, or I mean, there are sobering centers, but there's just one in Skid Row. And so I don't want to send everyone to the ER. That's not an appropriate use of their their time and services. So I want a place to put people right away until their permanent situation comes about. Because what happens is they die, they get picked up, they lose interest, they move, and it can take up to a year to find a place for someone. So I want a place for someone in the meantime. The other thing that I want places like my wish list. I want
Yeah.
places, I want to put people who are experiencing severe mental illness, I want a place to put them. So again, it could be interim housing, like temporary housing until we can find placement for them. It doesn't have to be a hospital. If they're gravely disabled but there's nothing acute going on, let's just put them somewhere that's inside, and not have
Right.
to go the emergency room route,
We're
right?
going to get these people off the streets. Absolutely.
So the problem though is with severely mentally ill, a lot of times they're very paranoid, very
Yeah.
hesitant to accept any resources, like things that don't make sense, like, you know, uh, even like cigarettes, like nothing, there's some people who just won't accept anything. So the thing that I'm most excited about that you asked is that we are starting to treat people of their mental illness. We're just doing it on the streets. We're not trying to well, unless it's emergent, we're not trying to hospitalize them anymore. We're not trying to drag a psychiatrist out to see them or drag them to mental health clinic, which is very difficult to handle for a person of sound mind, never mind like a paranoid disorganized mind. And so I'm very excited about these. There are injectable antipsychotics that last a month. There's
Depot
another one that
drugs.
lasts 3 months.
Yeah.
And this is the most exciting thing for me, to start using these medications with their permission. We're not doing anything involuntarily. We start them on orals, just to make sure that they don't, that they tolerate it,
Sure.
for maybe a few days or a week, and then we switch them to the injectables, and it's a 180. It's a game changer, and they accept resources so much easier. And it's like whatever was keeping them from, saying, hey, let's put you into Project Room Cure, and they're like, no, 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 no. And now they're like, yeah, okay, like
Yeah. That's great.
it's just so that's the thing that I'm trying to kind of spread the news about to other street clinicians. The Department of Mental Health does have a psychiatric outreach team, a couple of them. But there's like 5,000 people on the streets who need, so
Yeah.
as many people who can start, feeling savvy and learning about these particular psychiatric medications, and it really keeps them from being hospitalized.
Sure.
um, and some of them can actually handle, they can live on their own. They don't
Yeah.
need to be in a involuntary. Now some of them need to be in a boarding care because they're not really gonna, they're too far gone and they
Yeah.
just still can't take care of themselves. They're not as difficult, but so those are the things I work really hard to try to increase the capacity that we can place people who are severely mentally ill, from a policy legislative, begging perspective,
Yeah.
not the actual building of a facility, but yeah. So if we can kind of get, right now Medi-Cal doesn't pay for long-term psychiatric treatment. So if we can get Medi-Cal to pay for it, maybe we can have, places where people can really, feel safe and, I don't know, garden, do
Do their
ceramics,
thing. Yeah. Yeah.
whatever,
Yeah. Be productive.
you
Sure.
know, I'm not talking about hospital or state hospital or institution, I'm
Right.
trying to stay away from those buzzwords. Like I really, like if it were my kid or my mom or my sister, I want them in, a place where they're going to thrive,
Sure.
but be safe and be happy.
Right. Well, Homeless Healthcare Los Angeles, where you're the medical director, is the largest harm reduction organization in the United States, providing the needle exchange,
Mhm,
naloxone for overdose reversal, housing, hygiene services, and medical and behavioral health services.
mhm.
Doing it all, again, without judgment. Now, if people want to contribute to HHCLA, where can they go to do that?
I believe they can go to our website, which is www.hhcla.org.
Okay. Okay.
Yeah, and I'm sure there's somewhere in the website that directs them to how to
We'll put that link.
contribute.
We'll put that link on the podcast notes. And I want to thank you, Dr. Partovi, for being on the podcast and for all of
Easy.
God's work you and your organization do to help make a positive contribution to this homeless problem. I wish you all the best, and hopefully we pray the problem can be solved in the future. And just a personal note from this host, if you have a roof over your head and even one meal per day, be grateful you are blessed. These people on Skid Row have nothing. We all need to get off the couch and familiarize ourselves with our city's homeless problem and do whatever we can, such as donating socks, food, dog food, a
Mm.
toothbrush, anything else that can brighten some homeless person's day. I want to thank everyone for listening. I want everybody to stay safe. And for now, it's a wrap.